Thank you all for making the time to be here this morning to talk about the ASAM criteria. I think it's incredibly important for us to be familiar as helping professionals, whether you're working in the addiction treatment field or the mental health space, because there's so much overlap and co-occurrence between mental health and substance use disorders that you're bound to, if you are working in the behavioral healthcare field, interact with somebody who has substance use and or another addictive disorder. So having an idea of how to effectively assess and develop treatment plans is really important. And my personal stance on ASAM, I think even if you're not in an agency environment that requires the use of ASAM, it's still helpful to have an idea of the assessment dimensions that you should be looking at to give a full biopsychosocial perspective on the client that you're working with. And that's what I think ASAM does. So for the last, oh gosh, I can't think of how many years, Illinois specifically has been using ASAM, the third edition, for their substance use treatment providers as a requirement for how they fill out documentation and assessment. And there are a lot of payer sources with insurance that require the use of the ASAM criteria. As of July 1st, Illinois transitioned to using the fourth edition. So that's what we'll be covering for the sake of today. I have to give a brief disclaimer. I am an approved ASAM trainer, and part of the content that we'll be going over today is used with the permission of ASAM. A brief introduction. If you haven't worked with me before, my name is Dr. Jessica Love Jordan. I'm a trainer, consultant, therapist at my agency, Love Behavioral Health Consulting, where we do behavioral health workforce development training. I also do organizational wellness consulting and provide therapy services. I'm also an assistant professor at Governor State University in University Park, Illinois, in their Graduate Addiction Studies program. So I mentioned at the outset, we have a lot to cover in a little bit of time. Again, ASAM criteria is so in-depth that it really could be a training that's spread across multiple days. So with that said, I encourage you to, from today, continue to build onto your knowledge. So we'll cover the changes between the third edition and the fourth editions. For those of us who are familiar with the third, there are some, I think, really cool changes that ASAM has made to their criteria. So we'll talk about what those things are and then do a more in-depth look at the continuum of care and those assessment criteria and the decisional rules that you'll apply to being able to take that assessment information and make a level of care recommendation. And then with the time that we have left, we'll go through a few steps towards treatment planning. There's a few interactive exercises built in, and we'll have an active case study that we're working with as we go through those dimensional assessment criteria. So to start, the ASAM criteria was originally born from a lack of consensus. So in the 1980s, there was about 40 to 50 different criteria being used for care providers to justify the medical necessity for care. So 40 to 50 different sets of criteria by different insurers and utilization management. And there was so much variance and sometimes contradiction with how people were being assessed and placed in different levels of care. That led to the development of the patient placement criteria that was first established by ASAM in 1991. And over the years, it continued to be refined. In 1992, ASAM formed the Coalition for the National Clinical Criteria. They would go on to draft the ASAM PPC2 in 1996, and then the third edition in 2013, and now the fourth edition that was published a couple of years ago, but it's still kind of being rolled out in different states. Like I mentioned, Illinois just adopted it in July. So guiding principles for ASAM. Between the third and the fourth edition, the guiding principles or the foundational concepts are essentially the same. Admission to treatment is based on client need versus arbitrary prerequisites. And that's an important thing to note. Sometimes we'll find organizations or agency spaces that will prescribe a certain number of treatment encounters based on what insurance has approved versus what is clinically appropriate for the client. So, for example, if an individual comes in with a moderately low risk, but enough to meet diagnostic criteria to say that they need services, if they can reach their goals on an outcome, not an outcome, an outpatient level of care, in an outpatient level of care, ASAM says try to recommend the least restrictive but most appropriate level. We don't then want to, because the client was approved for inpatient care, require that they attend on an inpatient basis when they really could be successful in an outpatient level of care. So ASAM says that treatment recommendations need to be based on how the client presents and their needs versus, arbitrary things like how many sessions are provided or the schedule or availability of different clinicians. The guiding principles also suggest that the multidimensional assessment has to address a broad range of factors related to people's development of substance use disorder and what they need to establish recovery. Treatment plans need to be individualized and based on those multidimensional assessments. And then reassessment is what drives the patient movement through the continuum of care. And we'll talk more about what that means in a moment. Guiding principles also say that care is interdisciplinary. Based on evidence-based treatment, interdisciplinary meaning that there are multiple clinicians, multiple specialties that people really need access to have a holistic sense of care. And those things have to be based on evidence-based practices. So it can't be something that we saw on TikTok and think it's a cool intervention to try. It has to have some evidence-based, meaning that it has to have been tested multiple times in research and having the efficacy validated by that research. And then patient-centered care. So the ASAM criteria also recognizes that most clients who are going to present with substance use disorders also have comorbid mental health conditions. And they set the tone that that's the expectation and not the exception. And that's kind of a foundational concept throughout all of the standards that we're going to cover. So what is new with ASAM? So the major changes within the ASAM criteria is the dimensions, level of care, and how people progress through the continuum. So kind of a high-level overview, ASAM made these changes with the intention to promote more integrated care for things like withdrawal management. And we'll see when we look at the changes in the levels how withdrawal management is shifted to be integrated into every level versus its own separate level. The goal is also to promote client care with a focus on more shared decision-making versus the clinician being the sole expert in prescribing treatment to the client. It's more collaborative. And the updates were intended to improve and promote a more chronic care model that's reflective of how chronic substance use and other addictive disorders can be versus a one and done type of treatment. The chronic care model emphasizes continuity of care, making sure that people always have a way to re-engage versus you do detox, do IOP, and then that's it, you're supposed to be cured, right? If you are familiar with how addiction works, for some people, some places, some of the time, yes, that is absolutely the case. They only need the one treatment instance and they go on to live a happy, healthy life. But for the vast majority of people that are coping with substance use and other addictive disorders, it requires multiple rounds through treatment, right? Thinking about the stages of change, the idea that change is not a linear pathway, it's not a straight path. People often cycle through those different stages multiple times before it sticks and they're able to apply or kind of consolidate all the things that they've learned to be more second nature. But it can take some people years of cycling through those stages to establish that. So the shift in adopting more of a chronic care model embraces that, recognizing that people sometimes need multiple treatment stays to really establish long-term recovery. So one of the major changes when we think about the assessment criteria, a lot of the dimensions remain intact but expand, and there are some that have been switched. So for example, the third edition had readiness to change as the fourth criteria. That is still present in the fourth edition, except it's been integrated into every consideration, every dimension. So it doesn't go away. It doesn't go away at all. We always want to take into account how ready is the client to accept any recommendation that we're making, but that's taken into consideration at every dimension. We also see that dimension 5 has transitioned to be dimension 4 and expanded to include multiple substance related risks. So not just the risk for the individual continuing to engage in substance use or experience a recurrence of symptoms. It looks at things like, what are some of the behavioral risk factors? What is the likelihood of the individual being exposed to significant harm or destabilizing losses? So it kind of expands what we're considering to be risks, not just focusing on the potential for recurrence of symptoms. And then we see dimension 6 take the place of what was dimension 5, and look at recovery environment interactions. And that's more or less the same, looking at how the environment supports or doesn't support the individual establishing recovery. And then the new dimension 6 is person-centered considerations. And we'll talk more in depth about what that actually looks like in practice. But it's, in my mind, it feels a lot like the readiness to change, but more expansive. So it takes into consideration things like the client's motivation, but it also considers their preferences, any treatment barriers that they may experience, and what this looks like. And we'll see it with the assessment. Going through dimensions 1 through 5 gives us the material that we need to be able to identify what is going to be the least restrictive but most appropriate level of care. Looking at all of that, the next step would be to take the information that we gather from dimension 6, person-centered considerations, and then make our finalized treatment. So I mentioned that there was an update in dimensions. Another part of that update in dimensions is, and everybody can see the slide deck again, yes?
Yes.
Okay, fantastic. Now there's the addition of subdimensions. So it's things that we've likely been assessing all along, but now the ASAM criteria spells it out. These are the areas that you want to make sure you're assessing as you go through these different dimensions. And we'll look at what each of those mean more in depth in a few seconds. There's also the addition of dimensional drivers. So the concept of dimensional drivers is really just the factors that drive a recommendation for a specific level of care. And we'll look at all of those things as we're developing our idea of how to apply the assessment criteria. But dimensional drivers are specific to the individual, and it's what we ideally will focus on when we're developing an individualized treatment plan. And we reassess those periodically to determine, like to make sure that the individual is still appropriate for the level of care that they were placed in, or they may need to transition to something more intensive or less intensive. It's the dimensional drivers that we want to look at to assess that appropriateness. It's also things that we'll consider if somebody is being admitted to a new level of care. So think of them as the things that move people through the different levels and inform the new treatment plan. Other things that have changed, the levels look a lot different. So there were several significant changes to what's considered the continuum of care. One of the first things, 0.05, is no longer considered a level. To begin with, it was never considered a treatment level. It was early intervention or prevention. That has been eliminated. While early intervention and prevention services are important, they're typically provided in the major healthcare system. So ASAM addresses that in a different chapter of the ASAM text. The outpatient levels were also stratified to involve more progressive levels of medical involvement. So there's a new 1.0 level that we'll look at. And it was added to provide more long-term remission monitoring, where level 1 used to be just standard outpatient. There's more levels to that level. So in the third edition, level one included both office-based and medical care services and outpatient therapy and a separate level one for withdrawal management. The fourth edition defines that separately as having a level 1.5 to provide the outpatient therapy and 1.7 that involves the medical or managed care for different biomedical services and psychiatric comorbidities and things like withdrawal management. There's also a new level 2.7 that's medically managed intensive outpatient. And that provides, again, those same kind of withdrawal management, medication management, biomedical or services for different psychiatric comorbidities. The levels 3.1 and 3.5, they remain relatively unchanged, except now there's an expansion to how many hours are included in clinical services per week for level 3.1. And then they have also, ASAM has also eliminated the level 3.3 that used to be a specialized level for individuals with cognitive impairment, partly because it wasn't really being utilized. There weren't enough residential treatment providers that were able to provide that type of specialized care. And, you know, organizations generally did not understand the needs well enough to provide services for it, so ASAM eliminated it. There were so many limitations in just the understanding and availability of the care that it didn't really make sense to continue with it. So instead, managing cognitive impairments has been integrated throughout the continuum of care. So each level is going to have something that focuses on that. And this is just another highlight of those services. Like I mentioned, the early intervention and prevention has been shifted to a new chapter in the text. Some rearranging of some levels, some elimination of other levels. There's also this expectation that recovery support services and co-occurring care be provided at every level. Okay, so getting into the bulk of the presentation, looking at what the actual criteria says. So one of the core components of the ASAM criteria is the level of care assessment, and that's where we'll spend a lot of our time today. But that is essentially what informs every other decision that we make as people are moving through treatment. So the patient may enter treatment, have their level of care assessment, and then we as the clinician look at those dimensional admission criteria and make our recommendation. Ideally, the individual is going to start at the least restrictive but most appropriate level of care, which may be a higher intensity, and then titrate down, right? Progressively declining the intensity of their level of care until they exit the continuum. So moving through the continuum of care, starting at that high level and working their way down progressively, then transitioning to more continuing care services where there's less of an intensive focus on stabilization and more about maintaining. Throughout that process, we're always going to be assessing individuals, revising treatment plans to be reflective of how they're progressing or whether or not they need additional care services. And that process continues on until the individual exits the continuum. So this is what that new continuum with the changed levels of care looks like. Level 1 still deals with outpatient, but it has the addition of level 1.5, like I mentioned, and level 1.7. Level 2 continues to be intensive outpatient, but it's been expanded to include the medically managed intensive outpatient. Level 3 remains relatively the same, and level 4 is still medically managed inpatient. So something to note with the level of care distinctions, when you see the 0.1 or 0.5 or 0.7, 0.1 level care means that the individual is generally on the, I guess, milder spectrum of severity for that particular level. So like a level 2.1 is going to be much less intensive than a level 2.7. 0.5 levels of care are primarily driven by the dimensional factors 3 and 4 that deal with comorbid mental health or psychiatric conditions. Um, and it's usually psychotherapy based. And then the 0.7 levels of care are driven by dimensions 1 and 2 that deal with the acute need for medical stabilization. So if an individual is experiencing withdrawal symptoms or different biomedical conditions that may need stabilization for them to meaningfully engage in treatment. So looking specifically at level 1, and this is kind of a bird's eye view of it, level 1.0 deals with long-term remission monitoring, and that's usually the last level of care that we'll see people in before they phase out of the continuum. So it's going to be much less intensive than the other levels that we're going to go through, and it's really about providing, in my mind, a source of accountability for the individual, a touchstone for people to check in. And continue to engage in some level of treatment, but not at the same level of intensity that they may have started at because they don't need it, ideally by this point. So the overarching goal is, it can be delivered in a lot of outpatient settings, right? It can be delivered via telehealth and something as simple as, an individual therapy session or attending group once a week. But the goal is to maintain a therapeutic alliance so people can have, at a minimum, like quarterly checkups to support their recovery or assess if they need to re-engage in treatment services. So it's not necessarily tied to a specific treatment setting. Like I said, it can be offered virtually. It can be a part of a larger program. But the idea is that regular contact, again, quarterly at a minimum, having recovery management checkups, and those checkups should involve a level of assessment just to see how the client is doing, reworking the treatment plan if needed. Level 1.5 provides a lot of psychosocial services, and it's essentially a step up from level 1.0. It doesn't include medical staff, so it's not a medically managed type of outpatient, and it's what we consider to be traditional outpatient services. So again, that can include things like group. It can include individual therapy or family sessions. And then 1.7 is medically managed. So this is essentially where we would see people who can otherwise function in an outpatient level of care, but they may have an acute biomedical condition, or they may need support with withdrawal management, but are appropriate to do it at an ambulatory level. So they may be initially placed in a 1.7 until the biomedical concerns are stabilized for them to be able to engage in an outpatient therapy level. So level 2.1 remains intensive outpatient, or what we know to be IOP, and clinical services range between 9 and 19 hours a week. 2.5 is a step up from that, and it used to be called partial hospitalization, or PHP. It's now considered to be high intensity outpatient treatment. And it's high intensity because that tends to be 20 or more hours of care each week. Then the next step up from that is level 2.7 that provides that medically managed care. So when we're thinking about level 2, there's a lot of the same services that are offered in level 1. The clients will have access to therapy services, medication management, group, family, skills development, recovery supports, but the level of engagement, the frequency in which they're engaging in treatment is going to be more intensive. Whereas outpatient, you can come maybe once a week. Level 2.1, it's usually 3 to 4 days a week. PHP is like having a part-time job where the individual is there from 8 to 5, 4 to 5 days a week. Does that make sense? So do you see how it's building? Level 3 care, or residential care, is the next step up from that. So I have to be clear, residential is not the same as inpatient. I'll say that again. Residential is not the same as inpatient. What we consider to be inpatient is really that 3.7 level where it's medically managed. However, people can engage in residential treatment that's clinically managed, meaning it doesn't have that round-the-clock 24-hour care because they have some type of instability within their environment that threatens their ability to establish long-term recovery. So that's when we'll see people being recommended to that residential level of care when they need a stabilizing and at least monitored environment. So level 3.1, is generally recommended when people have more risk factors in the environment, but they're able to more or less manage themselves. It's focused more on building skills in a safe environment. So people will have access to psychosocial services and the therapeutic milieu, meaning that there's going to be staff on site 24 hours a day, just not medical staff on site 24 hours a day. And then programming follows a similar regimen as what an IOP would, except people don't go home. 3.5 is the clinically managed high-intensity residential treatment. And that's a step up in that people still have the 24-hour supervision, but when we have a 3.1 level of care, sometimes people can leave, like if they have to work or if they have appointments. We generally don't see that with a 3.5 level. Then the 3.7 is more medically managed, whereas 3.1 and 3.5 may have some monitoring. 3.7 is medically managed, and it's usually individuals who are experiencing some type of biomedical instability that requires them to have access to the 24/7 physician or like nursing staff. And they're typically seen by that medical staff at least once a day, where they may get vitals done in the morning, medication distribution, things of that nature. So even with the residential type of level of care, the assessment, and we see this across all the levels, if somebody enters in a high level of treatment, we want to continually be assessing them to see when they're going to be appropriate to step down to that level of care, to the next lowest level of care. So someone may start at a 3.7, and then after a few weeks, insurance rarely ever lets people stay for a few weeks, but let's say after 5 days, the individual is considered medically stable. Then we're either going to look at stepping them down to a 3.5 or 3.1 based on the rest of their psychosocial assessment, because it's really that dimension 2, the biomedical conditions, that drives the individual towards a more medically managed level of care. And this is an outline of all those medically managed levels. We talked about 1.7, 2.7, and 3.7. The last one that we'll talk about is level 4, which used to be detox, and that withdrawal management is still there. But level 4 is the most intensive level, where the focus is less on the psychosocial engagement. Those things are accessible, but the focus is more so on helping the individual to stabilize. Either they have some instability in dimension 1 that looks at them experiencing acute intoxication or withdrawal, or dimension 2 that involves biomedical conditions. So they could have, say, hypertension that hasn't been well managed, that needs stabilizing for them to be able to then engage in the lower levels of treatment or the psychosocial services. Or if somebody is experiencing psychosis, they may be more appropriate for to start services in a level 4 care so they can be stabilized and then be able to engage more fully with the psychosocial services. Not to say that people, when they're experiencing psychosis, can't engage in treatment, because they've done a lot of work in developing interventions specifically for individuals actively experiencing psychosis. But that's another topic for another day. So now that we know the levels, now we're going to look at how do we turn that into an assessment and recommendation? How do we get people into those different levels and determine which one is going to be the most appropriate? The answer to that is the level of care assessment. So the level of care assessment is essentially how we determine what is going to be the least restrictive but most appropriate level of care recommendation for the individual. And there's different assessments that we'll talk about today. There's a difference between a level of care assessment and a treatment assessment. Both of them are going to involve those assessment dimensions, but use it in different ways. So with the level of care assessment, it's only going to gather the information that we need to make that treatment recommendation, that treatment level recommendation. And the idea of least restrictive but most appropriate is something that I want you to keep in mind as we're going through this criteria, right? Sometimes we hear substance use or addiction and listen to the frequency in which people may be using and automatically think, nope, they need inpatient treatment. But the frequency of use in itself isn't enough to determine that. Because of that, ASAM has established assessment dimensions that we want to consider as we're trying to figure out what is going to be the least restrictive but most appropriate level of care. Those dimensions include subdimensions that we're going to talk about more in depth as we go through. But this kind of provides a framework for us to make sure that we're checking all the boxes for the areas that we want to examine when we're making that dimensional assessment. So the steps we want to go through with using the dimensional criteria. Number one, applying the assessment criteria to assign a risk category, which we'll go through. Then looking at what we've identified as risks from levels 1 through 5 and making an initial level of care determination. Then looking at dimension 6 and taking into consideration those personal characteristics and need areas of the individual. And from that information in step 2 and step 3, making our recommendation. So step 1, apply the dimensional criteria to assign a risk rating to each subdimension, starting with dimension 1 that looks at intoxication and associated risk. The subdimensions involved in that are intoxication and associated risk, withdrawal and associated risk, and addiction and medication needs. So intoxication and associated risk and withdrawal and associated risk were essentially what dimension 1 looked at. Now it includes addiction medication needs. When we're thinking about its intoxication and associated risk, it asks the question, is the individual currently intoxicated? And if so, what is the severity of it? Do they need some type of stabilization, right? Are they at risk for hurting themselves or hurting other people with their current level of intoxication? And there are different screening tools that you can use. A lot of biomedical screening tools that you can use to determine that. And then just familiarity with what some of the symptoms of intoxication look like. With withdrawal and associated risk, we're looking at the likelihood that the individual is going to experience withdrawal symptoms in the future based on their reported last use, any history of withdrawal symptoms, and what's the severity. And then with addiction medication needs, it's considering, is the individual going to need some type of medical management to get started on a maintenance medication? Or do they need, if they're currently using a maintenance medication, do they need support in being able to access that while they're engaging in treatment? So looking at the risk rating, starting with intoxication and associated risk. The letters are really just to differentiate. When you see the letters in these risk ratings, it's really just to differentiate between whether we're saying the individual needs the medically managed version of this level of care or not. So when you see the B, that's for bio, A means non-bio. So if we are assessing intoxication and the associated risk, and we identified that the individual is demonstrating very severe signs or symptoms, we know that's going to be a level 4 because there's something within their presentation that is going to need some type of stabilization. Something is making them a risk of imminent danger to themselves or someone else. If we assess the risk to be moderate, that would give them a 3B rating if they require some type of medical stabilization. And if the symptoms are moderate or severe, but they're manageable in an outpatient level of care, we may be looking at a level 2.7. But if there's mild symptoms or no symptoms, you're either going to assign an any rating, meaning that they can be admitted to any level of care appropriately, or 0 if there's no risk. The system for rating is essentially the same across the dimensions. With the more severe symptom presentation, it's going to be 3 or 4. Less severe, it's going to be like a 2 or a 1. So we talked a bit about some of the severe withdrawal symptoms and that needing stabilization. Again, alcohol, benzodiazepines, if they are severe. And they have screening tools like the CY and NAS, and I feel like there's another one that scales the severity of symptoms people are experiencing. So if somebody is getting a high rating on the CY scale or a NAS scale, that lets us know more than likely they're going to need some more intensive medically managed care. If it's not as severe, but severe enough that they need some type of medical management, but not an immediate crisis stabilization that you would see for somebody getting a level 4 recommendation, we would be looking to place them in a level 3.7 biomedical. If they're severe signs and symptoms, but they're treatable without the use of IV medications, or they're moderately severe and only require support and not management, we can see a level 3.7 or lower. A level 2.7 offers some management for moderately severe symptoms that are otherwise manageable in an outpatient level of care. We may assign a minimal risk rating of 1.7 if individuals are experiencing some mild symptoms that interfere with their daily functioning, but not to the point where they're debilitating, where we may see for an individual that requires a residential or an inpatient level of care. So an example of that, if somebody is experiencing stimulant withdrawal, there's not the same withdrawal management approach that alcohol withdrawal or benzodiazepine or opiate withdrawal would have. But there are some things that people can access in terms of medication for reducing some of the discomfort they may experience, right? So there's no established protocol like we would see with opiate withdrawal for stimulants like cocaine. But people still experience withdrawal symptoms that can make them uncomfortable and increase the likelihood of them returning to use to essentially stave off the discomfort. So people can experience agitation, anxiety, depressed mood, things that feel uncomfortable to sit with. But it's not to the same level of severity as you might see with somebody experiencing moderate to severe opiate withdrawal who may have all of those symptoms plus body aches and nausea and vomiting and a bunch of GI discomfort. So it acknowledges that people who may not experience the whole gamut of what we see with alcohol and opioids can still experience some discomfort as a part of them withdrawing from whatever their substance is, and offer medical management to address that. So it's not uncommon for people to be prescribed things like anxiolytics or anxiety medications or, something to deal with sleep disturbance, but not to the same level where they have to be under that constant medical monitoring. And then, of course, if the symptoms aren't notable or prominent or they're not existent, you risk rating of 0. With addiction medications, as clinicians, it's good to have an awareness of it, but we're not making any decisions in terms of medication goals. The biggest thing we want to pay attention to is looking at if the individual is either engaging in some type of or using some type of maintenance medication already, and if they need a continuance, or if they are requesting access or if it would be beneficial for them at least to have an evaluation for the appropriateness of maintenance medication, right? For us as counselors, this is more so about informing what type of referrals we're going to be making. So, in your registration page on Eventbrite, there is a folder that includes this case study if the print is not pleasing to your eyes, because I know sometimes on the screen it can look a little small. But this is Miss A. And we're going to be working with Miss A as we're going through and kind of solidifying our understanding of that risk assessment for each of the dimensions that we're going through. So take a moment and read about Miss A and think about, is there a risk for intoxication? Is there a risk that she might experience significant withdrawal symptoms? Might she need addiction medication? And if so, to what severity? Moving on to look at biomedical conditions. So the subdimensions that we want to pay attention to with biomedical conditions, of course, physical health concerns that the individual may experience, including things like chronic pain or chronic medical conditions. It's not uncommon for people, especially with severe substance use disorders, severe substance use disorders and or mental health concerns, to experience a lot of chronic health conditions like hypertension, diabetes, things like dental issues that we need to pay attention to. And that's twofold, right? When we're looking at biomedical conditions, we want to assess, is this person going to need some type of medical stabilization or intervention? And is the individual going to need a recommendation or referral for different services to address some of their physical health concerns? Right? So we're looking at, do they need stabilization? Do they need medical support? And are they going to need recommendations for something like a primary care physician or physical therapy or occupational therapy or an optometrist? Because all of these things, if we're thinking about the client holistically, right? If we're thinking about recovery, we want to make sure that we're helping clients get access to all of the things that can help them live healthfully. It's not just limited to the substance use piece, right? When we're thinking level of care assessment, for the sake of being able to identify what's going to be the least restrictive but most appropriate, paying attention to those physical health concerns is paramount, because that can make the difference between an individual engaging in level 2.1 intensive outpatient or level 2.7 medically managed intensive high intensity outpatient. So we want to think about physical health concerns. We also want to consider pregnancy related concerns, right? Because women also experience substance use issues. And pregnant moms, pregnant women are special populations that don't always get the care and sensitivity that they need, partly because of stigma, right? But we want to take that into consideration too when we're thinking about level of care, because when there's mom and baby involved, we have to be mindful of the physical health risks, not just for mom, but for baby. Making sure that they're getting access to prenatal and OBGYN care, because that's important to their overall well-being too. And just looking at the overall medical risk for both mom and baby. So taking those things into consideration, if you're assessing a woman and she has not had access to prenatal care, we want to take that into consideration to make sure she's able to get access and make sure that baby is getting monitoring. There may be a need for maintenance medication, and there's different protocols for pregnant women. So all of those things need to be taken into consideration versus just saying outpatient and that's it. What if mom has medical needs for support throughout her pregnancy? We also want to pay attention to things like sleep. Sleep, in my opinion, is such an important but underrated factor in our overall well-being. And it is not uncommon for individuals, especially in the earlier stages of recovery, to experience sleep disturbance. Then when we consider like how often people experience comorbid conditions like anxiety and depression that can also cause sleep disturbance, it's very likely that those effects can compound and essentially create a risk for return to use or recurrence of symptoms for a lot of people. Think about the recovery acronym HALT: hungry, angry, lonely, tired. It suggested that, especially in early recovery, people try to avoid allowing themselves to reach a place of feeling hungry, angry, lonely, or tired because those things, fatigue, can impact our cognition and can impact our impulse control, right? So if I'm not sleeping well, I'm more likely to be irritable. And if irritation was a trigger for me using, that kind of creates the perfect storm. So we want to make sure when we're thinking about my biomedical conditions, in addition to the more obvious physical health concerns, we want to talk to people about how they're sleeping, because sometimes that can make a difference. So in terms of assessing risk in this dimension, it's similar to what we looked at with dimension 1, with a risk rating 4 being more appropriate for individuals who are experiencing health problems that require some type of acute care in the physical health concerns area. And if that is the case, they're most appropriate for that level 4 care because it's going to offer them that medical management for the sake of stabilization. And then titrating down in the same way. There may be severe problems, but not as severe or acute as would be required for level 4, but they still need medication management through things like IV medication or some type of wound care. Then we would be looking at a 3.7 bio. It would be a risk rating 3A if there's not the need for the bio care. Risk rating of 2 if the problems are manageable in a medically managed outpatient level. And then risk rating of 1 if we identify that the problems are there and they're moderate and impacting daily function, but not so much that it has to be a more intensive level of care. And then if the risk rating is any, meaning that the problems that they are experiencing can realistically be addressed at any level, they don't have to have medical management, you can risk rate it as any. But if there's no risk, if there's no concerns in the physical health area, of course, that risk rating would be 0. Same type of format for pregnancy-related concerns. If the individual is at risk for experiencing immediate or imminent harm or instability in the pregnancy, we would want to recommend a level 4. If the individual needs after-hours monitoring or the support of a therapeutic milieu, we'd be looking at level 3.7. If they need non-life-threatening care support, they can function at a level 2.7 because it's not the crisis stabilization that we would see with a level 4, but there still needs to be some medical monitoring to support them in their day-to-day. And then if the individual is experiencing some risk that requires on-site prenatal care, but it's relatively low or what we would expect to be associated with a normal pregnancy, risk rating 1. If there are low to average complications, risk rating of any, meaning that they could be treated at any level of care. And of course, if the individual is not pregnant, the risk rating in that area for that subdimension would be 0. So thinking about Miss A, are there any physical health concerns that require a rating? Does she carry a pregnancy risk rating? So if we think about it, Miss A has hypertension that is not well controlled with medication. Thinking about the physical health concerns, we want to pay attention to hypertension because it's not well controlled even with medication. And if we think about her CWAS score, that's the withdrawal screening for alcohol, she had a score of 7, which suggests she's experiencing mild alcohol withdrawal symptoms and has a history of experiencing moderate severity with withdrawal. considering when she had her last drink and the amount that she's drinking, we can say it's possible that she could experience an increase in her blood pressure because that's a symptom of alcohol withdrawal. And in her case, because she already has hypertension that's not well managed and her current blood pressure is pretty high, there's a good chance that she's going to experience an increase in that and it's going to need some medical stabilization. So if you were thinking maybe level 4, maybe level 3.7, based on the biomedical presentation, I would say that's probably an accurate assessment. Okay, so for dimension 3, it looks at psychiatric and cognitive conditions. So we want to be assessing for the presence of active psychiatric symptoms, if the individual has a history of persistent disability, if there are any impairments to the individual's cognitive functioning, if they have any trauma-related needs or trauma history that needs to be taken into account, and if they have an already documented psychiatric or cognitive diagnosis. So this particular level of care is focused more so on assessing whether these symptoms are persistent and significant enough that the individual needs a certain level of supervision or monitoring or management for the sake of them being able to be considered stable, right? So as I mentioned before in the overview of the criteria, the expectation now is that all levels of care involve some type of co-occurring disorders enhancement. So there's some type of skilled mental health intervention and higher level of staff support that can address mental health concerns that individuals may present with, and provide some type of psychiatric management or oversight. So for this particular level, this particular dimension, we want to think about things like symptom management. Is the individual going to need support in that area? Are they going to need referrals based on our facility's capability to address the mental health concerns, right? Are they going to need ongoing engagement with providers? Say we're an inpatient provider, and we only offer inpatient or detoxification services. How they're assessing in this dimension is going to determine what kind of referrals or recommendations or transition services that we're connecting clients to. So we want to consider things like the individual's need for medication management, if they are experiencing acute symptoms that need to be stabilized for the sake of their own safety, things of that nature. So when we're looking at risk assessment, it's going to follow that same pattern, with a risk rating 4 being the highest level of severity and often matching the highest level of care. So if somebody is experiencing or poses an immediate or imminent risk to themselves or other people and require that urgent type of psychiatric stabilization, we're going to be looking at a risk rating of 4. And that more or less translates into a level of care that's that 4. The next step down would be a risk rating of B or 3B, where there's acute symptoms present and they need the 24-hour management, but not to the same level of intensity as a level of 4 care would offer. Same thing, risk rating A. The symptoms are acute, but not to the point where they're a risk to their safety, but it does require some intensive interventions. And that would translate into a level 3.5, noticing that all of these are co-occurring enhanced levels of care, ideally. So then we'd be looking at a risk rating of 2B when there's the need for some type of medical management or the bio concerns, and the individual is experiencing psychiatric symptoms that interfere with their recovery and need the daily monitoring. 2A, when they need the clinical management but not medical management, right? Meaning they have access to medical staff, but it's not to the same level of intensity as somebody actively managing the individual's care. We'd assign a risk rating of 1 or 1C, if they're experiencing psychiatric symptoms that require some type of medical monitoring, but not to the same level of intensity as a 2 level of care like the intensive outpatient. But because they require that medical management portion, we would recommend them to a level 1.7. And then if the individual is experiencing mild symptoms, but they can more or less manage them individually, and they really just need the support, 1.5. And if symptoms are mild to moderate, manageable at any level of care, you would give them a risk rating of any. If there's no immediate psychiatric symptoms, you would give them a risk rating of 0. Same applies for persistent disability. So thinking about cognitive impairment. If an individual is experiencing kind of a baseline of impairments in their ability to process information or organize schedules or engage in things like group therapy because they're experiencing persistent mental health symptoms or some type of disability or intellectual or developmental disability, or like a traumatic brain injury or some type of neurodiversity that requires more flexible treatment options, we would be looking at a risk rating of 1Z and recommend them to a 1.5 level of care. But if they have some persistent disability present, but not to the severity where it's going to impact or significantly impact their ability to engage in treatment, we'd be looking at a risk rating of any, and then 0 if nothing is present. So thinking about Miss A, make a mental note. In her case, do you notice any active psychiatric symptoms? And if so, what risk rating would you assign to them? Same thing. Does it seem like she's experiencing any type of persistent disability? And if so, what risk rating would you assign? Moving on to dimension 4 that looks at substance-related risk. This particular dimension considers both the likelihood of the individual engaging in continued substance use and the likelihood that they're going to experience harm or consequences associated with that risk, as well as the likelihood of them engaging in risky behaviors related to their substance use. So those risky behaviors can include things like gambling or risky sexual behaviors or violent behaviors, risky behaviors like the ones we're more familiar with, like a DUI or DWI or other illegal activities like that. So in assessing this particular dimension, we want to think about it in terms of serious harm, destabilizing loss, and negative but not necessarily destabilizing consequences. Think about harms that are likely to occur or become imminent in the span of hours or days, not necessarily weeks or months, right? So thinking about more immediate risk versus the long-term what could possibly happen when we're making the level of care determination for this area. So we're determining the individual's risk for related substance use, ongoing substance use, and whether any of those things require supervision or recovery support services to reduce the level of risk. Is that making sense? So you want to think about what's the likelihood of the individual continuing to engage in substance use? What's the likelihood that they're going to experience negative consequences or some type of harm from continuing in substance use or engaging in other risky behaviors? And to what extent might they experience harm or destabilizing loss, like losing income, losing their job, losing their home, or custody of their children? Those are what we consider to be destabilizing losses. Or other negative consequences that may not be destabilizing loss, but significant enough where the individual experiences some discomfort or distress. Um, so things like family conflict or relationship conflict, legal challenges, other losses that aren't considered to be destabilizing and that people can still recover from them. So when we're assessing the risk, and these letters are kind of arbitrary, but when we're assessing the risk, they would get a risk rating of E, looking specifically at likelihood of substance use. If the individual is at a high likelihood of engaging in ongoing substance use with a significant risk for harm or experiencing a destabilizing loss to the point where they need 24-hour support, we would be looking at a 3.5 level of care and a risk rating of E. It can also be appropriate if the individual meets the criteria for level 1, but they're experiencing instability in levels 2 or 3 that require the 24-hour supervision. We would assign a risk rating of D and recommend a level 3.1 if the individual is experiencing a moderate likelihood of continuing to engage in substance use with risk of harm or some type of destabilizing loss, and they demonstrate the capacity to develop relapse prevention skills. If that's the case, they're more appropriate to function at a residential level without the clinical management or medical monitoring or medical management. We would be looking at a risk rating of C and making a level of care recommendation or thinking about a level of care recommendation of 2.5 if the individual is experiencing a moderate likelihood of continuing use with significant risk or harm, and they demonstrate the ability to develop relapse prevention skills or prevent ongoing substance use with that daily interaction. And they meet level 2.1 criteria, but there's some instability in dimension 3 that requires a more intensive services. For an individual to be appropriate for a minimum level 2.1 recommendation, they would need a risk rating of B. That says there's a low likelihood of them engaging in risky use. And if there's a very low likelihood of them engaging in risky use, they would get a rating of A and be appropriate for a level 1.5 care. So thinking about likelihood of risky substance use disorder related behaviors, and we kind of have a rhythm for how we're applying the rating and what that translates into for the minimum level of care for each of these subdimensions. Of course, if there's a high likelihood and there's the need for 24-hour clinical support, we'd be looking at a 3.5 level of care with a risk rating of E. And if there's less of a need for support, but they still need the residential structure, risk rating of D and a minimum 3.1 level of care. If there's a moderate likelihood of substance-related behaviors, but it's relatively manageable with a higher level of intensity outpatient services, we'd be looking at a minimum level of 2.5 care and a risk rating of C. And when you see it says minimum level of care, that's what you want to think about with least restrictive and most appropriate. That does not mean that has to be the level of care. But it does mean for the individual, if they're meeting this criteria, that is the minimum level that they would be able to enter in. So if we assess that the individual has a D rating for the likelihood of substance use related behaviors, at a minimum, they should be recommended for a residential or 3.1 level of care. We may build on to that and ultimately recommend something that's more intensive based on how they're assessing risk in the other dimensions. But at a minimum, they would need to be looking at a 3.1 level. Make sense? If you walk away with nothing else, think about least restrictive, but most appropriate. Historically, treatment providers have taken a top-down approach, starting with the most intensive, regardless of the client presentation, and then making them work down from there. But that's not always appropriate, right? We don't have to throw everything at people to start off because they may be able to be successful at an outpatient level of care. Okay, so we have a general sense for how to assess the risk and establish that risk rating. Yes? Thinking about the likelihood of risk behaviors for Miss A, do you think she has a risky substance use rating or some considerable risk related to other substance related behaviors? And if so, make a mental note of that. The fifth dimension looks at recovery environment interactions. So within that, we want to look at things like the individual's ability to function in their current environment, whether they're safe in their current environment, whether they have supports in their current environment, and if their cultural environment, right, their geographical location, if those things, the social norms, may help or hurt their chances of establishing recovery. And that's the kind of assessment that we want to do with each of these subdimensions. Thinking about the individual's current functioning capacity in the environment, does it help or does it hurt the likelihood of them being able to establish recovery? The safety of the environment, is it conducive to their recovery or is it a risk factor, right? Do their social contacts help or hurt the likelihood of them establishing recovery? You know, we want to consider the individual's skills, like their social and interpersonal skills, whether or not they can engage in, the skills of daily living, like grocery shopping, cleaning their home, maintaining a medication regimen, um, thinking about the relationships. We know a lot of the time, especially as people progress towards a more severe substance use or other addictive disorder, lifestyle tends to shift to center around the addictive behavior. So it's likely that the individual will have a lot of social contacts that are also engaging in substance use. If we're expecting the individual to be able to establish recovery, what do we do about the relationships? Right? So with all of the other dimension areas, we want to be assessing for what is the need for stabilization, but also how is this going to inform, right? How is this going to inform the treatment recommendations that I'll make later when I get to the planning part? So kind of tucking that in the back of your mind. In terms of assessing risk, we want to think about it in terms of impairment. If the individual is experiencing severe functional impairment, we know that's going to require a lot of support. So those more therapist-led habilitative services that can be offered at a 3.5 level of care are going to be appropriate. If the individual is experiencing moderate impairment, and they would benefit from that therapeutic milieu access they would have at a 3.1 level of care, that makes an appropriate recommendation for them. If the individual is experiencing some impairment, but they don't need the 24-hour care, a 2.5 would be a more appropriate recommendation. And then if the individual is experiencing moderate functional impairment and would benefit from some clinical services, but not to the extent of the high intensity, a 2.1 or an intensive outpatient is an appropriate recommendation. And then if they can function at any level, you would give them an any rating. If there's no risk, you would give them a 0 rating. Same applies for safety in the current environment. If there are things that threaten the individual's safety, or they require safe housing or stable housing, it's not a recommendation for residential. It is a recommendation for recovery of residents or recovery housing. And then if there's no risk rating, of course, there would be a 0 if there's no specific needs. Thinking about support in the current environment, If there's no interactions that are supportive of their recovery, that's something we want to take into consideration because we're social creatures by nature. So if the individual meets the criteria for outpatient level of treatment, but there are interactions in dimensions 1, 2, or 3, or 4, that suggests that that outpatient isn't going to be sufficient, we'd be looking at a 3-point level, a 3.1 level of care. If the current social environment doesn't provide adequate support to cope with their substance use concerns, and the environment experiences some safety concern, or the individual experiences some safety concerns in their environment, recovery residence may be more appropriate. If the environment is not optimal, but okay enough for them to engage in outpatient treatment without the intensity of residential support, we can essentially say they can function at any level of care. And if there's nothing in the environment that poses a significant threat to their support, we would give them a risk rating of 0. All right. So we have reached step 2, where we want to take into consideration all of those things that we noted with the subdimensions for dimensions 1 through 5 and make an initial level of care recommendation. So you want to think about, does the client need acute care? If there's some type of instability in dimensions 1, 2, or 3, chances are the answer is yes, the client does need acute care. If we're thinking, is there a need for medically managed care? If the individual doesn't require something as intensive as a level 4, but there's some instability that does need to be addressed, maybe medically managed care is appropriate. Thinking about residential. If they don't require medically managed care, but they do need the support of a therapeutic milieu and after hours care, maybe residential is appropriate. And then if the individual doesn't require medically managed or residential or monitored care, maybe outpatient is appropriate. After we come to that initial determination based on dimensions 1 through 5, we want to look at dimension 6, those person-centered considerations. So thinking about the individual's ability to engage in whatever treatment we're recommending, thinking about the client's preferences, thinking about individual needs and their readiness to change, and also being mindful of different social determinants of health that may be affecting the individual in their ability to establish and maintain recovery. So when we're assessing dimension 6, we want to think about, what are some of those barriers to care? What does the client actually want for their treatment? Do they need different motivational enhancements to help them engage? Because we have to consider that the level of care recommendation that we make may not actually work for the client, right? If the person is a single parent and they have no one to care for their children while they're in residential, we have to take those things into consideration. So clinically, residential program may be the most appropriate thing, but unless we're able to connect the client to programming that is appropriate for families, it's difficult to make that recommendation and expect people to follow it. Is that making sense? So thinking about barriers to care, it can be things like having caregiver responsibilities. It can be things like finances or insurance or transportation, or if people are employed, not being able to take time off of work, especially if they don't have those type of benefits. It could be things like cultural barriers or societal perceptions, or things like stigma or not having access to the different therapies needed. So using Illinois as an example, we've actually post-pandemic experienced a lot of facility closures, which is concerning because the number of facilities that we had that were effective and evidence-based was already limited. So for example, the Women's Treatment Center ran for years, and they were one of the few facilities that accommodated moms. They closed a couple of years ago. So thinking about those kind of societal barriers when we're making treatment recommendations, we also want to consider client preferences. It's not uncommon for a lot of treatment facilities to have a zero tolerance, abstinence from day one type of approach when we know now through research and evidence that that doesn't work for everybody, right? So making sure that we're matching as much as we can or accommodating as much as we can clients' preferences for how they're engaging in treatment. Maybe people, want to have access to virtual services in addition to their in-person services, giving people options as much as we can. People like to have a menu of options. And then need for motivational enhancement. I have found that when we come in heavy with a recommendation for care, it's not uncommon for people to, especially if they're in the earlier stages of readiness to change, be a little ambivalent about accepting that recommendation. If I'm in a position where I am just coming into awareness or still unaware or uninterested in changing my substance use, for you as the clinician to say to me, well, I think you need an inpatient level of care, I'm not going to be accepting of that because I haven't accepted the fact that I need help at all. Is that making sense? So we want to make sure we're taking these things into consideration, right? Dimensions 1 through 5 help us to identify the least restrictive, but most appropriate. This is another dimension for assessing what's going to be the best fit. Mandated clients. Yes, if a client is mandated, there is a chance that they may be a little reluctant to take a treatment recommendation. That does not mean that we can't work with them, right? I actually really enjoy working with mandated clients because they have incentive to show up. The trick becomes us helping them enhance their level of motivation. So once that external pressure of being mandated is removed, that they've identified within themselves why they would keep going with the change. But these are the person-centered dimensions that we want to take into consideration, right? We may have a recommendation that conflicts with what the client wants, and when that happens, because that happens, if we recommend a level of care that ultimately doesn't work for the client, our job is to collaborate with the client to identify, okay, what's the next best thing? What can we do in terms of harm reduction that would make a lesser intensive level more appropriate for you? So for example, if somebody is interested in receiving medication-assisted therapies, but they can't or aren't interested in attending the group, whereas 2.1 may be the best thing for them, we might be able to find a way to make it so they're appropriate for like a level 1.7, where they still have access to the medication services and support and some access to the therapeutic services, but people may be able to engage with more of like an expert or brief motivational interviewing to help them work through the ambivalence that they're experiencing around receiving the more intensive therapeutic services. Does that make sense? Now, that's not to say that the individual's readiness to change should affect their ability to access or receive different treatments. But we do want to consider it more so during treatment planning, and considering what might be some hindrances in individual accepting our recommendation. And then if we need to, adjusting our level of care, right? We want to consider accessibility. It's appropriate to adjust the level of care recommendation if we identify that what might be the least restrictive but most appropriate level of care isn't accessible to the individual. Like the example I gave with the Women's Treatment Center. Residential may work, it might be the best thing, but if we can't connect them to a residential treatment facility that accommodates what their life requires, we have to take that into consideration. Same thing, we might adjust the level of care recommendation based on the client's preferences because that's important too. Or if they have specific needs, right? If we're a 3.1 residential facility that does not include medication management or medical medical monitoring or medical management, it may not be appropriate to recommend somebody engage in services with us if they have the need for regular medical management for something like dialysis, right? If they don't have transportation that would be able to take them to report their appointments every day, it may be more appropriate to recommend something that's medically managed. Does that make sense? So we'll have an idea of what's going to make clinical sense for the individual. I think taking that Dimension 6 assessment of the individual's person-centered needs makes it more practical, right? It makes it more client-centered, where we're not just prescribing what the book says, even though those dimensions are important to consider, especially when it comes to safety. But the Dimension 6 kind of invites the focus to the client back into the room. So now we're going to put it into practice. You've gone through the process of formulating what's going to be the least restrictive but most appropriate level of care recommendation for Ms. A. But she appears to be ambivalent towards your recommendation. So now we have to look at Dimension 6. I mean, we're going to look at Dimension 6 anyway. But looking at Dimension 6 to determine, okay, what are the barriers to care? What are the client's preferences? What is her motivation? And how do we collaborate with the individual to come up with something that she's going to be willing to commit to? All right, welcome back. So, what did you all come up with? What is the level of care recommendation that you would make for Miss A?
Oh, I came up with a 3.7.
I
That's what
said
I
three.
came up with.
We said three. Well, no.
I said three. Letitia and I said 3.1.
3.1? Okay.
Yeah.
Only because he's reluctant. Yeah.
Okay.
We listening?
You want to know why?
Yes.
Yeah. I was supposed to elaborate. Okay. Well, based on our medical needs as well as the mental health needs, right? And their experience in withdrawal symptoms prior. I didn't get a chance to read the full. Okay. Thank you so much.
Got it.
Yeah. All right. Now, again, the age factor goes in, but she has currently mild withdrawal syndromes, right? And she's experienced some withdrawal symptoms prior, and she's continuing to consume alcohol at the moment while still trying to, I guess, recover or treatment. And again, Letitia, help me out.
Okay. Well, okay. I am torn between 3.1 and 3.7.
Okay.
The reason I was saying 3.7 is because she has a lot of health concerns. It's not controlled, even medication. And along with the mental health diagnosis, she is not in compliance. So, and then with her environment, I mean, she's saying, like we were talking about the social norm, that she has support. However, many of her friends are drinking. So, in regards to her saying that her environment, she has some relapse prevention skills, but I don't think it's working. Looking at what's happening now, so it is going to be a struggle with her, and I know that she's going to probably struggle with the her own was it client? What are we looking for? Client consideration. It may be a back and forth, but I think the motivational interviewing will probably get her to go along with the 3.7. But that was, I know I was going back and forth between the two. Is she going to go along with it? Do we want to push her too far? And she may say no, or should we just really go for the medical, I mean, the motivational enhancement and push that envelope and see where it goes.
Okay. So if I could challenge that a bit, what about her case suggests that her environment is to the point where she needs the 24-hour milieu support? So we
She does.
think about the recovery environment and interactions. Granted, that is not the sole factor to consider when we're looking at a residential or an inpatient level of care. But if you think about level 3.1, that is our standard residential, where the idea is there's something in the environment that is creating instability that threatens the individual's likelihood to be able to engage in treatment, right? They may be experiencing, well, we can go back and look at some of the risks. Dimension.
Yes, that's why I think she needs more attention because of mental issues. And her mental issues will continue to keep her unstable because it takes her, she's indecisive on what she actually wants to do, and she needs more help.
So your concern is in dimension 3.
Yes.
So it sounds like Paul and Leticia, most of the concern was the environment. So dimension 5 seems to have a higher risk in your perspective. And Larry, you feel like it's dimension 3, the mental health concerns that need to be given more consideration. So it sounds like everybody's leaning towards level 3 care, just figuring out which sub-level is going to be the most appropriate. Is that where we're at?
I think so. Yeah. But I'm looking at that whole management of common psychiatric disorder. That is concerning because you're not staying in compliance.
You said she has not.
I'm looking at, no, she hasn't been, she's not staying in compliance for her medication for the mental health disorder. So with that, I'm really leaning towards that 3.7.
Now, keeping in mind, each level, whether it's level 1, 2, or 3, has the ability to offer medically managed care where people can get access to things like withdrawal management support, medication management, right? So if that
I forgot about that part. Yeah.
If that's the medical management need is what you all are considering, you can access that at an outpatient level or an intensive outpatient level. So then thinking about the dimensional criteria, if it's the concerns in dimensions 1, 2, or 3 that deal with really the need for medical stabilization, we can address those. Unless there's like an acute crisis, then we'd be looking at a level 4 recommendation. But if there's a need for some type of medical monitoring or stabilization, we can do that at regular intensity, high intensity, residential level of care. So then we have to expand to look at what are the risks in the other dimensions, right? Thinking about her case, and I can bring that case study back up. Thinking about Miss A, we know that she has some risk, not in the acute intoxication, because her last drink was 2 hours ago, and it takes about 2 hours to metabolize a standard drink. So let's assume that she had one drink in that day, and it was 2 hours ago. So we can say she's not actively intoxicated. There's a 0 risk rating for that subdimension. If we look at the risk rating for withdrawal and associated risks, we can see by her CWA score demonstrating the mild withdrawal symptoms present, and make a clinical judgment that because of how much she has been drinking, because of how much she's been drinking, because of how long she's been drinking, and her history of experiencing moderate severity withdrawal symptoms, there's a decent likelihood that she's going to experience in the next couple of hours moderate or maybe severe withdrawal symptoms, right? Because it's only been 2 hours since the last drink, and historically, she's consumed 5 to 6 drinks per day. So her body is accustomed to having a fairly steady state of alcohol. So we may just be at the tip of the iceberg of withdrawal symptoms if she's already has a CWA score of 7 and it's only been 2 hours. Right? So taking that into consideration, we can say maybe she has a moderate risk in that category, right? A B level risk. So with that said, maybe that 3.7 is the most appropriate, but we still have to keep looking, right? Thinking about dimension 2, biomedical conditions. We know blood pressure has been a concern. And we kind of talked about that earlier, where her going through alcohol withdrawal can exacerbate that. And it may require some medical stabilization. That's something we have to take into consideration. So if we're thinking about dimension 2 and the physical health concern ratings, she may not need IV medication, right? Unless they're medicating severe withdrawal symptoms, but we don't know that she's going to experience severe withdrawal symptoms, right? So then maybe 3.7 might be more intensive than what she actually needs, at least in terms of physical health concerns. But there are physical health concerns present. So maybe we're looking at a 2.7. We still have to expand it to think about the rest of the dimensional criteria, right? So we know there's maybe some moderate risk when it comes to withdrawal symptoms, moderate risk when it comes to physical health concerns, right? We determine that she's not pregnant. Thinking about dimension 3 that looks at psychiatric concerns or cognitive conditions, she's diagnosed with major depressive disorder and general anxiety disorder and has medication but has not been compliant. So thinking about that, there's nothing saying that she is symptomatic, but we do know that alcohol withdrawal can sometimes cause depressed moods and increases in anxiety. So that's something that we have to take into consideration. But there's nothing suggesting that she needs immediate psychiatric stabilization, right? She doesn't, at least from the perspective of psychiatric symptoms, appear to be presenting a significant harm of threat to herself or other people, right? Nothing in her case said that she was experiencing psychosis or suicidal or homicidal ideation. So we can say that there's no immediate crisis, but that doesn't mean we don't take into consideration that she has a diagnosed or 2 diagnosed mental health conditions that can be exacerbated by continued alcohol use and alcohol withdrawal, right? So if we identify that her symptoms can interfere with recovery, but she doesn't necessarily need a level 4 type of stabilization, but she needs some support for managing symptoms, maybe we can look at a level 2 or a level 3 if we find that her symptoms are significant enough. Does it make sense how we consider the dimensional criteria?
Yes.
Right? So we may land at 1, but then when we start to consider how the other factors influence each other, right, that kind of creates a little more flexibility with the care recommendation that we may make. Questions on that? So thinking about it in that context, are we going level 3.7, level 3.1, maybe a level 3.5? Or does she need level 4? Or something else entirely?
I'm still feeling a 3.7.
3.7?
I'm still feeling that, yeah, because of the
Right?
medical aspect. It has me really concerned.
Mm-hmm. Considering her history and her current presentation, there were some concerns in the medical realm for sure. But this is an example of how to apply the assessment criteria to making a level care determination. We good on that? Yes, no, maybe so?
I still don't have the answer.
That's okay. That's okay. So the
But because I still believe in level 3.7 because her condition is gonna, from experience, her condition is gonna get worse.
Mhm.
That's my opinion. It's gonna get worse and she need help now before it does.
Yes. So
That's why I picked 3.7.
I think we can all agree that some supports are needed. It's just a matter of determining what's going to be the least restrictive, but most appropriate. And that may be a level 3.7, right?
Okay.
So when you're out in the field doing this type of assessment, you want
Okay.
to make sure that you're documenting having looked at all of those subdimensions and provided your interpretation of the risk rating so you can justify whatever level of care recommendation that you're making,
Okay.
right?
Okay. Yes.
Because it's all, there's a science to it, but then an element of it is clinical judgment. And the expectation isn't for you to leave today and have everything down pat. It just doesn't work like that, right? So hopefully this is the first of, a handful of trainings that you'll go through to really wrap your mind around it. My recommendation, especially if you're in internship or going to internship or currently working in the field, I think practice is the best teacher, right? So when you're doing your intake assessments, thinking about it in terms of ASAM criteria, and if you're reporting to payer sources, like having to do utilization management reviews or, prior authorizations where you have to prove medical necessity, ASAM criteria is your guidebook.
Okay.
Anyway, so the last thing that we'll focus on, treatment planning. So we've gone through the process of identifying the risk areas in the client's biopsychosocial presentation by going through withdrawal concerns, biomedical conditions, psychiatric concerns, things that we know, if unaddressed and there is risk, can complicate treatment. We want to take all that into consideration when we then transition to treatment planning. So we assess the risk in all the dimensions. We made the level of care recommendation based on those risks. The client has accepted that recommendation, and now they are in their level of care. Treatment planning needs to be reflective of that. It needs to be reflective of the client's identified needs, right? And sometimes that is kind of dictated by the environment. Like, of course, it's all going to be individualized as much as we possibly can. But there are going to be treatment services that are available in a level 3.7 care that aren't going to be available in a level 1.5 care. Is that making sense? So the level of care determines what kind of recommendations we're able to make. The treatment planning assessment determines what kind of recommendations we need to make. Does that make sense? So with treatment planning, reassessment, and review, we want to look at what strategies are working, what's not working. Is there new information that comes up when we do a treatment plan review that suggests we need to change something in the plan or change the level of care or make some type of adjustment, right? In terms of that treatment planning process, it starts with identifying the problem areas. So remember when we were going through and looking at the different dimensions, making that mental note of this may determine the treatment, but it also provides information on what type of challenges the individual is experiencing and how that needs to be addressed in treatment. It may also inform what kind of recommendations we're making. So we want to look at those dimensions and subdimensions and identify what are the dimensional drivers, right? What are the problems in each subdimension that require care? And which of them are significant enough to drive how we're providing that care? So in that, when we're developing a treatment plan, we want to work or collaborate with the client to identify what are going to be their goals, the objectives, and the action steps that they're willing to take. Notice I said their goals. Like, of course, we are going to have our treatment goals, the things that we would like for the client to accomplish for the sake of them being able to establish and maintain long-term recovery. We also want to make sure that what the client wants is integrated into that, because people are more likely to buy in to whatever we're prescribing if they've had a hand in developing it. So we're going to have clear treatment goals, right? It may be something like the individual, if they're in an outpatient level of care, will participate in 3 IOP sessions each week for a period of at least 6 weeks. That's our treatment goal, right? That's a very clinician-driven goal. The client may have the goal of, I want to improve my communication skills so I can start to repair my relationships. Both have a place in the treatment plan, right? Because we may identify the recovery environment has a lot of risk factors because their relationships aren't supportive, right? The client may identify on a more micro level that I really don't feel like I have the skill set to develop new relationships. And that may be a hindrance in letting go of the ones that aren't supportive. Is that making sense? So we want to take into consideration, of course, the bigger treatment goals, the bigger recovery goals, but then what the client actually wants too. You know, reflecting the patient's priorities, making sure that the goals that we're including are meaningful to them. And we want to make sure that the objectives related to that are appropriate for the level of care that they are engaging in. So we can't make a residential level of care objective in an outpatient level of care environment. Other things we want to consider when we're treatment planning, making sure that it's individualized and based on our assessment. We also want to make sure that it's measurable. We can have an idea of what's considered a successful outcome and have a way of tracking that. So it's not just a kind of floating goal or a not well-defined goal, so people can have a plan for how they're approaching it. We also want to make sure that we have contingency plans in place just in case symptoms tend to worsen before they get better. because we know sometimes that's par for the course for some people, some places, some of the time, right? But having that plan, it's better to have it and not need it versus need it and not have it. Same thing applies with safety planning, especially if we identify that the individual has some instability in dimensions 1, 2, or 3, making sure that we're taking that into consideration with how we're developing the plan so we can ensure that they're going to be safe with whatever treatment we're recommending. And of course, transition planning. We want to be planning for the client's discharge from their intake, right? Because the goal is not to keep people in treatment or therapy forever. We want to be thinking about what is this individual going to need to successfully move through the continuum of care and establish recovery and heal in a way to where they're no longer going to need treatment services at the very beginning. And structure our treatment plan really based on that, right? We want to get people out of the continuum. That's the goal. So prescribing treatments that support that. And thinking continuity of care, right? So treatment in itself, I think it's helpful to consider treatment more so about stabilization. And that being the focus, people are not always going to need stabilization. Ideally, they're going to reach a place where they're stable and just may need continuing care for additional support. Continuing care isn't going to be the same thing as a treatment level of care, right? That may take the form of mutual support groups, right? Engaging with recovery support specialists or, individual therapy separate from a treatment environment. But care coordination is an important part of treatment planning as well. Then when it comes to treatment plan updates, we always want to be assessing. Like we talked about earlier, the information that we have available at intake is going to look different than what we may have at, 5 days of engagement or 5 weeks of engagement. So we always want to be assessing. And ideally, as the person is progressing through treatment, they're going to experience improvement in their symptoms, which means they're ultimately going to need a less intensive level of care. So we always want to be thinking about how the person is progressing and when it's going to be appropriate to step them down to the next least restrictive level until they titrate out the continuum. Right? So we want to think about, are there signs or symptoms that need consideration? Is the client making progress? Are they not making progress at the current level? We also want to consider, are there more standardized assessments that we expect to change over time that needs to be repeated to kind of track their progress? So things like a PHQ-9 or a depression screening or an anxiety screening or, a pain scale. Things that we hope are going to look different as the individual progresses through treatment. We want to make sure that we're assessing those on an ongoing basis. Also thinking about, have the dimensional drivers changed? Whereas in the case of Miss A, we identified that her medical concerns were a significant dimensional driver. Her psychiatric concerns were a significant dimensional driver. And it seemed like the recovery environment was maybe a mild consideration. Ideally, over time, we're going to see that shift, where if she's engaging in a 3.7 level of care and getting that medical management, hopefully her biomedical concerns become less of a dimensional driver because she's experiencing stabilization in that area. Same thing with the mental health symptoms. So it may switch over time, where she may have initially entered treatment at a 3.7 level of care because that level of care did what it needed to do. Now she's more stable in her mental health symptoms and her physical health symptoms to where she can really engage in treatment in an outpatient level of care. But we have to be doing that ongoing assessment to be able to determine those things. Questions on any of that? So I have included a copy of the slide deck in the materials for today's training. There are a few more slides that we're not going to get to because we are way over time. But those will be available to kind of review that go through some of the services that you can expect to be associated with different dimensions. So for example, if we're developing a treatment plan and looking at dimension 3, this is where we want to address things like the need for psychosocial services or medications and talk about how we're going to coordinate care in terms of getting different referrals, or how often the client may need to engage in medication management services. Same thing if we look at dimension 5. That portion of the treatment plan may talk about something like building up the client's skills for acts of daily living, or involving some type of family intervention, or building up their support network. Okay. Questions for me? I know we covered a lot.
No, I just want to say this has been great and very beneficial, and I really appreciate you having this session.
Absolutely. Absolutely. I appreciate you guys spending 3 hours with me on a Tuesday. So if at any point you have questions, my contact information is here. This is the first of what will become a quarterly series of behavioral health workforce development trainings. So the next one will be in October and focus on counseling approaches for co-occurring disorders. That registration information will be available in Eventbrite and on the Love BH Consulting website. With this being the first, I'm really interested. I'm always going to be interested in feedback, but I'm especially interested in feedback today. So if you have a few minutes, this QR code will take you to an evaluation survey. Please take a moment and offer some feedback on what you thought about this presentation. And if you really, really loved it, it would be great if you can leave a review on Google. So again, if you have any questions, feel free to reach out. Otherwise, hopefully I'll see you all in October.